So hi everyone, I'm here with Professor Mark Soloway, one of the great leaders of urologic oncology, a great reference, world known, and we just saw a course about about bladder cancer. So I'd like to know, Professor Soloway, some insights for the Brazilian urologist about how to improve quality in treating those patients with non-muscle invasive bladder cancer and about TURBT.
Well, that's a big subject. First of all, hello to my good friends in all parts of Brazil, which I haven't been in a while, but I've been to many of the cities. And of course, you're our neighbors up in Miami. You know, we see a lot of you quite frequently. So first of all, regarding low-grade TA, which is the most common tumor, the papillary tumors, I think it's important not to over-treat them. So I do office cautery and even sometimes in older patients an anticoagulation. They have a little teeny tumors, come back in 3 months, 6 months. Office cautery, if you can take them off anticoagulation or they're not on anticoagulation, I use that really frequently. I don't biopsy them because urologists are very good at saying, "Hi, that's a low-grade TA tumor." They've had them previous, so just cauterize them in the office, works very well. With the high-grade T1, which is a big problem, of course, if the initial diagnosis, high-grade T1, you have to do a re-TUR, and then, depend on the result of that, make a decision, BCG, if you've removed all the tumor. If it turns out to be high-grade T2 or T3, then of course you have to consider neoadjuvant chemotherapy and then cystectomy. One of the important, I think, changes is that bladder preservation for muscle-invasive bladder cancer is getting better. Now using either cisplatin or with combination radiation therapy after a complete TUR. So if you have a patient 72 years old, for example, with a muscle-invasive urothelial carcinoma, and you think you've done a pretty good TUR, you've gotten almost all the tumor out, then I think they should have a discussion with chemo and radiation therapy to try and preserve the bladder. The results are really, honestly, equivalent to cystectomy if you have a patient that meets the criteria of having done a complete TURBT. So I think some of the highlights of the meeting so far.
Great. And do you think, like for prostate cancer, normally when we receive a patient, we talk to him about radiotherapy or surgery as equal therapies. Do you think we are there in bladder cancer? For most patients, we should talk about trimodal therapy or surgery as equal?
In the properly selected patients, to be honest, although I'm a urologist and a cystectomy is a difficult operation, but our results are better and better, particularly when we can offer a neobladder for quality of life. But nonetheless, if you've done a complete TUR, let's say a solitary, with no carcinoma in situ, no hydronephrosis, then the results absolutely are trimodality therapy. But again, you have to have the combination of a urologist who can do a complete TUR. You have to have a good radiation oncologist and a good medical oncologist. So if you're in a group that you don't have all those professionals, then obviously, and you're a good surgeon, then maybe a cystectomy is going to be better.
Great. It's not an easy treatment. You have to have a good team.
Exactly.
And one thing that you said during the event was about the tips that you use or how you talk to your anesthesiologist during TURBT. Could you tell us a little bit about that?
Yeah, I think it's very important to, if you have anything beside a little low-grade tumor, then the patient should have general anesthesia paralyzed. Because the worst thing is you're starting to do a TURBT and the patient moves. Or the patient, so if they have an LMA and they're not paralyzed, then you have to worry about that. So I want the patient paralyzed, general anesthesia, and now all the anesthesiologists know for Soloway's TURBT, the patient gets an endotracheal tube and paralysis.
Great. And one more question. You are one of the fathers of cisplatin in bladder cancer. What do you think are the best candidates for doing neoadjuvant treatment for a muscle-invasive disease, of course. But which patients do you think we should operate directly, and which patients do you think we should do neoadjuvant treatment?
No, that's a very good question. The problem is our staging is very imperfect. So you may think it's T2, that I don't need neoadjuvant, and then you get in there and they have positive nodes, and you say, or the bladder's a little bit stuck. Hey, I wish I had given neoadjuvant chemotherapy. So what I do is I encourage, by the guidelines, to use cisplatin-based chemotherapy if their renal function is good, their cardiac function is good, and then proceed with neoadjuvant chemotherapy. However, I think after 2 cycles, I always do cystoscopy, because if they haven't had a good response, platinum is a black and white drug like BCG. It either works really well or doesn't work at all. And you as a urologist are going to know by looking in the bladder. If the tumor is still there, then either go to immunotherapy or go to the cystectomy. So I think that's an important message. If they're looking like a good candidate, they've done very well, then you give a 3rd cycle. Then the problem is, 1, you can do a cystectomy, or if there's no tumor there, now you have to say to the patient, do we really need to take your bladder out? And that's a very tough discussion. There's no perfect answer there.
Great. So thank you so much. Thank you very, very much, Professor Soloway. It was great to have you here.
I enjoyed it, always. Hello to Brazil.
Thank you.